Hi, let's talk about primary hyperaldosteronism. Let's start with a clinical case. A 35-year-old male comes to the clinic with resistant hypertension. He's already on 3 different medications according to guideline recommendations, but his blood pressure is still not controlled. He's experiencing headaches, which can definitely occur with poorly controlled hypertension. Otherwise, he's relatively asymptomatic. Now, why is this case important and related to hyperaldosteronism? Because this young patient with resistant hypertension should make you think beyond essential hypertension. So what could be going on here? Most cases of arterial hypertension are primary or essential, so there is no specific cause to be identified, but in 10% of cases there is a specific origin, for example due to hormonal activity in the body, which can lead to hypertension, which is often difficult to treat. Primary hyperaldosteronism is the leading cause of this so-called secondary hypertension, so the leading cause of those 10% of cases. But how? Let's begin with the physiology of aldosterone and the so-called renin-angiotensin-aldosterone system, short RAAS. Aldosterone is a steroid hormone produced by the adrenal glands with profound effects on the kidneys. The function of aldosterone is to increase blood volume and therefore stabilize blood pressure by reabsorbing more sodium and passively chloride, since these ions carry water with them. So this is going to increase blood volume and blood pressure. So when is the RAAS active? When do we need higher aldosterone levels in the blood? Physiologically, when perfusion in the body drops. The kidney senses a drop in perfusion in its arteries by checking the salt concentration in the ultrafiltrate in the proximal tubule and releases renin when the GFR is low. The GFR is low when there is poor perfusion in the renal arteries. It's lowest in areas of low blood pressure, e.g. due to low blood volume. Then renin is secreted and via a cascade, eventually aldosterone synthesis increases. How does aldosterone do this? Again, it's a steroid hormone, and since they are lipophilic, it can simply diffuse into cells. When diffusing into renal cells in the distal tubulus, it binds to an intracellular receptor, the so-called mineralocorticoid receptor. It then stimulates the expression of certain ion channels, one for sodium, the so-called ENaC, which is the epithelial sodium channel, one for potassium, the so-called ROMK, and both of them are found on the luminal sides towards the filtrate. And lastly, aldosterone stimulates the expression of the well-known sodium-potassium ATPase, but this time on the basolateral side, so towards the blood, not towards the lumen. Then arriving sodium can enter the cells through the channels that are more expressed now, so there are more of them, and then sodium ions exit into the blood via the increase of the pump. In exchange for the loss of positively charged ion sodium in the lumen, now potassium exits the cell into the filtrate, which is going to become the urine to maintain electroneutrality. So for every sodium going into the blood in the end, one potassium exits into the lumen, so into the urine. Additionally, aldosterone stimulates the luminal expression of proton pumps in the so-called intercalated type A cells, which are also found in the distal tubule. They pump hydrogen ions into the lumen, so into the urine, and therefore more bicarbonate is going to be left or to be found in the blood, which is going to make the urine more acidic and the blood more alkalotic. So to summarize, aldosterone is the mediator of the RAAS, which increases blood volume by reabsorbing more sodium in exchange for potassium. And it also acts on the pH homeostasis by stimulating the expression of proton pumps in the distal tubule. So what's the deal with hyperaldosteronism then? What happens when these channels are expressed too much due to high levels of aldosterone? You might expect the classic triad: hypertension due to too much sodium retention, hypokalemia due to potassium wasting into the urine, and metabolic alkalosis due to proton secretion into the urine, which is going to make an increase of bicarbonate in the blood. These are considered the classic triad of primary hyperaldosteronism. But here's the key point: this triad doesn't always occur. In fact, most patients with primary hyperaldosteronism have normal potassium in the blood. So don't rule out hyperaldosteronism just because potassium might be normal. How does primary hyperaldosteronism, also known as Conn Syndrome, occur then? First of all, it's called primary because it's a condition where aldosterone is elevated independently of the RAAS, so the primary production has increased. The aldosterone production is autonomous, meaning it's not responding to the normal regulation signals from the RAAS. Therefore, renin is suppressed in primary hyperaldosteronism because the body is trying to compensate for the excess autonomous production of aldosterone. What causes this? There are two main causes. First, we have unilateral aldosterone-producing adenomas. This is a single tumor in one adrenal gland that's pumping out aldosterone autonomously. Second, and this is actually more common than the adenoma, there's bilateral adrenal hyperplasia, so an increase in cell size of both adrenal glands. In fact, about 2/3 of primary hyperaldosteronism cases are due to bilateral hyperplasia and not adenomas. So how could you tell the difference? This is where adrenal venous sampling, or AVS, comes in. Why is this distinction so important? Because it might change the treatment approach by doctors. If it's a unilateral adenoma, the patient might be cured with surgery. If it's a bilateral hyperplasia, the patient, on the other hand, might be treated medically with mineralocorticoid receptor antagonists like spironolactone. What about imaging, you might ask? CT imaging alone isn't enough because it can't tell if a nodule is actually producing aldosterone or if it's just an incidental finding. In this context, tests like a salt tolerance test might be helpful. Let's wrap this up with the key takeaways. First, think of primary hyperaldosteronism in any patient with resistant hypertension, so hypertension with more than 3 different first-line medications. Also think of primary hyperaldosteronism if the patient is rather young. Second, remember that most patients are normokalemic, meaning that there is normal potassium level in the blood. Hypokalemia might happen and is part of the Classic Triad, and you can check out this video on the mechanisms of low potassium to learn more about hypokalemia. Third, bilateral adrenal hyperplasia is actually more common than unilateral adenoma. And lastly, adrenal venous sampling is essential for distinguishing unilateral from bilateral disease because it determines whether the patient might need surgery or rather pharmacological therapy. I hope this video was helpful to you, and I see you in the next video.